7. So we are happy that you're here. Good to see a lot of familiar faces. So thank you for coming tonight. And we have 2 outstanding individuals with us this evening. We have Dr. Deborah Hazen-Martin, who is the coordinator of the curriculum at MUSC. And she's going to present first and talk with us a little bit about the curriculum that they have recently implemented there. So I think you'll find what she has to say to be very interesting. And then after Dr. Hazen-Martin's presentation, then Ms. Wanda Taylor, who is the Director of Admissions at MUSC, will provide you with a lot of good information about admissions. And I think both of these individuals would be open for you to raise your hand, ask questions. So this doesn't have to be a real formal, sort of interaction thing. So if you have questions, don't hesitate to raise your hand. And then afterwards as well, we'll have plenty of time for you to ask questions and interact with Wanda and Deborah. So I'll turn the presentation over to Deborah at this time.
Hello, I'm going to use this because I have a very soft voice, I'm told. And it tends to fade away with time, so I'll use this. First of all, I'd like to thank all of you for your interest in our medical school. We're really proud of our medical school. We feel that we have an awful lot to offer to all of you. And one thing that we are especially proud of is our new curriculum, which we call our integrated curriculum. Last year at this time, when I talked with students, I said we have a new curriculum that we've planned for and we think it's going to be great. This year, I can tell you, we have a new curriculum and it is great. The students are thriving using this curriculum. The results that we're seeing from them are incredible. More than just good test scores. When they go to see standardized patients and go into the clinic, we're hearing from clinicians and nationally trained standardized patients that, well, first of all, they say, what have you done to them? Well, that scared me at first. And I said, what do you mean? And they said, well, they're acting like third-year students in their first year. They're professional, they're comfortable in this clinical environment. So we take all of those things together as a very good sign, because that was what we were aiming for. We were aiming for a curriculum that, beyond getting them good board scores, would produce absolutely superb clinicians, physicians. So no matter which area of specialty they were choosing. So I'd like to take this opportunity to tell you a little bit about our curriculum and explain why we changed our curriculum. First of all, I will tell you that we're not unique. We are probably one of about between 30 and 40% of the medical schools in the nation that work with the systems-based curriculum. But there are parts of our new curriculum that I don't think you would find in any other medical institution. So the way we implement it has a lot of unique components. And people said, why do you want to change? Your students, after the first half of their medical school curriculum, when they take their step 1 of national boards, they're passing well above the national pass rate. Your scores are improving every year. Why do you want to fix something that isn't broken? Well, this is a quote from one of my favorite people at the Medical University of South Carolina, Dr. Jenny Ariel, who is the director for the Center for Academic Excellence and the Writing Center. And she actually, we talked about this and she sent this to me in an email. Doing things the same way, even though you were successful in the past, does not ensure success in the future, because times are changing. The volume of material that we could teach to medical students is enormous. When I was in school and entered with the medical school class, cell biology was a new thing. We didn't even talk about molecular biology. And now our first-year medical students have complete coverage of genetics, molecular genetics, and molecular biology. So if we just kept on adding on and adding on new information as it came in, you can imagine the consequences. You might feel like this little girl in this picture. So we accept responsibility for finding the clinically relevant information that every medical student should learn. But beyond that, we were hearing from clinicians. When our second-year students would pass boards and move into their clinical years, clinicians were calling me and saying, don't you teach them anything about acid and base? Why is it they don't understand this, that, or the other thing? And I said, of course we teach them that. You know, they scored very well on their boards. And it was clear, we were teaching them well, they were scoring very well on boards, but why is it that when they got to clinics, they weren't carrying that basic science information into the clinic and integrating it well with clinical practice? And so all those comments put together led me to believe it was because we never taught it that way. We never did a really great job, and I speak for our own medical school and the 60% of others out there. We separated basic science and clinical science, so kept them so siloed that students really did not learn to integrate when they got to the patient's bedside. So that is why we changed our curriculum. Now, changing a whole medical school curriculum is a very frightening job because the students are still going to take those boards and they're still going to be at a patient's bedside, and if things don't go well, I'll have a lot of explaining to do, won't I? And so we didn't go into this in a cavalier way. I had the wonderful fortune of being named Associate Dean for Curriculum Integration, and I should share with you, and some of you I already told this, I am first and foremost a teacher. I teach gross anatomy, and I love teaching gross anatomy. I teach general pathology, and I love that too. So I liked what I did in the old curriculum, and so did all of these people in this room with me. But I was given the opportunity to recruit and assemble our finest medical school teachers. When you all get to medical school, you will elect one of your professors each year as your best professor of the year. And you'll give that person the Golden Apple Award. It happens at every medical school across the country, perhaps in Canada, I think. And it's quite an honor to receive the Golden Apple Award. And I like to tell people that I spent 3 to 5 hours every single week with a whole bushel basket of golden apples every week for, well, actually I still spend 3 to 5 hours a week every week as we continue to evaluate our progress. So we worked for a full year, and we did some pilot projects involving simulation and standardized patients and other methods of teaching before we actually changed the curriculum. We looked at student comments, we did a great deal of self-evaluation, and we looked at curricula that were already in place at other schools. And as I said, we really didn't model after anyone else's curriculum. What we have is quite unique. So the first thing we did, which was hard for an old gross anatomist to do, but we threw away courses. We no longer have courses because we realized that what a lot of students were doing, you know, you all are in undergraduate school, and I think the system here is the same. You have semesters. You take, what, 3, 4, sometimes 5 courses each semester. And if you all are anything like I was in undergraduate school, I can tell you the day I took that last organic chemistry final, I said, I'm so glad I never have to look at that again. Well, believe it or not, some of our students would get through gross anatomy and say, gee, I'm glad that's over, you know. Phew, that's behind me. So everything was so siloed that they really weren't taking information effectively from course to course or semester to semester. So instead of courses, we have 4 themes for the first year, and these run throughout the entire first year. And I'm sure you can tell by the names of the themes, the top one, structure and function. I'm sure you can imagine what would be included in terms of content. It includes anatomy at all levels, gross, histology, embryology or developmental anatomy. It includes physiology and the structural components of cell biology. Homeostasis and regulation is all about control at various levels, either at the neuronal level with neuroscience, hormone level with endocrinology, genetics, and then mechanisms of cellular control. How is cell activity controlled, and what are the mechanisms for cell signaling? Food and fuel is the third theme, and that includes biochemistry, molecular biochemistry, and nutrition. And we recognize the need to increase our emphasis on both practical and biochemical aspects of nutrition. It's a subject matter that is poorly taught by all medical schools. And until we teach it in an effective way, it's unlikely we can truly produce a physician who will understand preventative medicine. And so, given our concern for the rate of obesity in our nation, and especially in our pediatric population, we were committed to really improving the nutrition portion of the curriculum. And finally, fundamentals of patient care. This involves the skills you need to truly be a hands-on physician. And we divided fundamentals of patient care into two parts, not structurally, but in terms of focus. One is focused on the patient. So you learn interviewing skills. You start on that, believe it or not, in your first week of medical school with us. You learn the skills involved in physical diagnosis, as well as in critical thinking and decision-making for the patient. And then, most important, is patient diversity. You will, as physicians, future physicians, should be treating a very diverse population, both in terms of age, cultural backgrounds, ethnic backgrounds. If you think that your practice, or if you expect members of your practice or your patient base to be exactly like you, and to have the same background, sets of values that you have, there's no way you can effectively care for those patients. So we do all that we can do to encourage you to acquire a real understanding for some of the cultural values and differences in our population that patients bring to the doctor's office. And that's been a very successful part of our curriculum and our medical school activity. Beyond the patient, the other portion of fundamentals of patient care focuses on you, the developing physician. We want for you to understand how to stay healthy as a practicing physician. I hate to tell you, but if you become a physician, your lifespan has just decreased. If you're a woman, it's worse. It's even worse than that of men. And why is that? Well, you have the pressures, you work long hours, you're very, very busy. So we believe that we can help you build a life in medicine. Medicine is a way of life. You give up a great deal to practice medicine, but you don't have to give up the things that keep you healthy. We give you skills to make sure that you stay healthy and well so that your patients can be healthy as well. Careers in medicine is an important portion of this course, and we help you in your decision-making from day one, believe it or not, so that by the time you get to the point in your medical school career that you have to determine which residency program you want to be involved in, you'll be ready. You'll have chosen a residency that fits your likes, your dislikes, you have the lifestyle that you want, and perhaps your family circumstances. And we insist on your professional behavior. It used to be that we kind of let you go wild for the first 2 years. You could wear anything, do anything, have your pranks in the first 2 years, and then suddenly we expected you, when you entered the clinic, to suddenly somehow become trained physicians and to act like physicians. And we realized that that can't happen overnight either. So on the very first day of medical school, in fact, before the first day, on the day that you receive your first stethoscope, your first white coat, and you take your oath to acquire the professional behavior that's involved in practicing as a